So here we're going to go into all the reasons why we don't like doing elbow replacements as much as we used to. And this picture actually illustrates one of the major problems that we see long term is when we have this catastrophic osteolysis, and it becomes very difficult to reconstruct these folks. What we'll look at through this talk is the major complications related to total elbow arthroplasty, and we'll divide that up into then intraoperative complications and then early and late postoperative complications, with right now there being a lot of debate about loosening of stems and what's the source of that, which is fairly controversial right now. Morey and Bryan in 1982 reviewed a number of their elbow replacements that they did, and what they found was when they had to revise them, 25% came from loosening, and then a smaller percentage came from instability and infection. I will mention, though, that for total elbows in the United States, they have the highest infection rate of any arthroplasty, so we're always concerned about that. There's a couple of complicating reasons for that. One is the number of rheumatoid patients that are on immunosuppressive medication affects that, as well as their poor soft tissue envelope. Other complications that led to requiring surgery were nerve entrapment and triceps insufficiency, and then ankylosis, or HO, is a very uncommon problem that they had. But there were additionally morbidity problems that showed that there is a high complication rate with this, and these included wound problems, nerve paresthesias, and those often and usually are your ulnar nerve, and most specifically have a lot to do with how careful you are evaluating your patient. And then humeral and ulnar fractures, which you can see from that initial picture, those will certainly develop over time. Folks have then looked at comparing RA to post-traumatics and if there's a difference. And essentially what they discovered when they looked at that is that the post-traumatics tend to have a higher complication rate, but a lot of it has to do with the implant and implant failure. And often that's related to the use of the implant by that post-traumatic patient. And you can see that here by loosening noted radiologically, but then additionally disassembly in terms of the implants. So intraoperative complications. There was a recorded study, and they evaluated the process in the operating room. And what they found was the inaccurate cutting guides, instrument failure, cementing, and inexperienced staff were the main causes of intraoperative complications. When it comes to instability, in terms of early postoperative complication, these have been localized. These have essentially been more related to the unconstrained implants. I will tell you, though, when we start looking at some of the later postoperative data, if they get through this early postoperative period without instability, then they tend to do well. And then really the only general mortality that's been studied was, again, by the Mayo folks, and essentially what they showed was the 90-day post-op mortality was less than 1% at 0.6, and the only statistical risk factor for that was distal humeral fracture non-union, and that had more to do with an indication of how sick the patient was than anything else. Another major early triceps problem, or early postoperative problem, is triceps insufficiency. And like many of these, Seeley evaluated this. And what they found when they looked at all the triceps insufficiency patients, interestingly, the Achilles allografts and anconeus flaps that they did better than direct repairs. And then additionally, they advocated if there was significant ulnar bone loss that you required a Achilles allograft with bone. But when we looked when this group looked more specifically at triceps on versus the heel and the Bryan Morey approach, there really is a significant difference in terms of how the patients do, and that has to do with outcome, which you can see here. Using the Mayo Elbow Performance Score, the preserving the triceps has significantly better functional outcomes than the folks that had the reflecting. Ulnar nerve lesions are very, very common, usually not like this example here. But one of the major issues with them is it's difficult a lot of times to determine risk factors due to confounding issues. But essentially, Stern, when he presented his findings, he essentially pointed out that it's important to take a very careful preoperative evaluation, and that includes both the exam, but then the history, if they've had previous surgery, to know potentially if they've had the nerve moved before, and any symptoms they may have had. Unfortunately, sometimes folks will have subclinical symptoms that then become more symptomatic after surgery. And postoperative risks that could potentially occur are nerve subluxation or problems related to dressings and hematomas. So as I mentioned, infections, they're highest for total elbows, and we mentioned the reasons why that is. They can include both superficial and deep infections. And the overall, and one of the studies we mentioned before had an infection rate of about 8%, which is significant, which is getting close to 1 of every 10 patients that you do an elbow replacement on is going to get infected. How do we prevent infection? Well, one, it can be the approach. Leaving the triceps on maintains the soft tissue envelope better. I typically, along with this, always use antibiotic impregnated cement. And then importantly, we try to keep the patients, immobilized if it's needed and not too aggressive with therapy. 2 studies have looked at the infection outcomes and in terms of what recommendations there are. Scott Wolf at HSS, they determined these were major risk factors for infection. But this study was just a collection of their patients, and so it really isn't studied statistically and carefully that any of these are specifically very statistically significant. Yamaguchi, when he was at Mayo, they reviewed their data, which was 757 total elbow replacements, and they divided them into 3 groups in terms of the treatment, either IND with retention, removal and replantation, or resection arthroplasty. And some of their conclusions were somewhat pragmatic and obvious. One specifically being resection arthroplasty was the only way to eradicate infection. But the other things that they noted was for component retention, if they had staph epi, that it wasn't an appropriate thing to do if the infection was more than 30 days. And replantation required good bone stock and the patient to be medically stable. Late postoperative complications, there's numerous ones, and these a lot have to do with specifics related to the implants. And this lists both unconstrained and semi-constrained implants in terms of the overall outcome. One thing I would note, the Aldridge study, which a lot of folks like to mention or bring up because of the fact that they had a 17.5-year survivorship for their study participants. They also eliminated about 24 or half of their folks if the implant didn't survive past 10 years. So basically they just looked at the folks that made it past 10 years to see how long they did, which was an obviously confounding variable in terms of their success. And that's basically what's getting at here with the mean survival at 17.5 years. So besides the differences in implants that result in complications, there's additionally complications related to the indications for why we put these in. Inflammatory arthritis, we do see aseptic loosening with it, but it's less common and it usually happens sooner than for post-traumatic arthritis. But we do see bushing wear in rheumatoid arthritis in the same way, but usually the cause is a little different, and usually the cause with the bushing wear in rheumatoid arthritis has to do with the overall soft tissue envelope and instability in terms of their soft tissues and the wear of it. Overall, though, you can see that the RA patients can do fairly well, just like the post-traumatics. Schneeberger looked more specifically at his post-traumatics and his semi-constrained patients, and overall they did well, but what he started to find was the ulnar mechanical failures were due to non-compliance, and that was illustrated more so both in this study by Hildebrand, but even more so with the Mayo data that I'll show you in just a minute. This shows you again all the options, all the indications that it's been used for, and they've been successful with variable amounts. But one of the things on that data, as well as it has to do with implant-specific complications, and these have changed over the years. The Pritchard Walker implant early on had a fracturing of the humeral component. The GSB implant had difficulty with disassembly. I have a lot of data here about the Coonrod-Morey implant, and part of that is because that Bernie Morey has been really good about keeping all that data, which is nice because he has this now collection of data that he's able to publish up to 30 years. And we see the changes both in the component changes, but then also technically what they've done. So in 1981, the early components had plasma spray on them, and they caused a significant synovitis, and so they had to stop doing that. In '84, the titanium beaded surfaces caused a stress riser, which you can see in the ulna here, and they had significant fractures. And then in 1991, they had a polymethacrylate pre-coat, and they had to stop doing that because of essentially delamination and loosening related to the cement. And as you see, there's been a lot of iterations, and they've been able to adapt in terms of these complications over time. Other complications they've seen have to do with the titanium axis pin. Early on, it was held in place with just a C, basically a small C retaining ring. And the positive to that ring was that if it came off, you knew that there was significant bushing wear. The downside is that it required you to go back and revise the patient. The newest implant doesn't have that. It has two sleeves that connect together to prevent that disassembly. For unconstrained implants, such as the ones listed here, these are the ones that essentially have issues with instability, and they additionally have aseptic loosening, and some of the information that helps with determining that, because it can sometimes be subtle, has to do with any kind of anterior tilt or medial tilt that clearly indicates loosening. But additionally, there's aseptic loosening in the linked total elbow replacement. And initially, it was more related very specifically to the implant design. And just like Roger Dee's first implant, the Coonrod 1 implant was a constrained implant, and so that created significant stress and loosening. Further, the concern was with the flange on the front of the implant was added to the humerus to prevent posterior displacement, because I was concerned that that would additionally contribute to loosening, although that hasn't really turned out to be as much of a concern in case. When the Mayo folks looked at their data more carefully, the initial feeling was that a lot of this aseptic loosening was related to cement technique, and this was supported by the fact that as the advanced cementing techniques were developed, loosening went away. However, as we'll see just in a little bit, that it's not just related to cementing technique in terms of aseptic loosening. And this is where we started, well, this is going to transition into that in terms of bushing wear. But Wright looked at some of this data, and they showed, first of all, that constrained and unconstrained designs can be essentially the same. And this was further supported by Little in terms of their data that they reviewed. But what the Wright study looked at more specifically is bushing wear could be definitely determined by the C-ring coming off. But then additionally, some of these other studies showed that a lot of the issues with bushing wear have to do either with non-compliant patients or just essentially time. The longer essentially the implants are in there, the more you're going to have wear. And so that's been a challenge in terms of coming up with an implant with this semi-constrained design that has a poly wear that will last longer. Ramsey in 1999, they looked at things radiographically, and what they showed was that if there was a 7-degree change in that measurement, that there was some wear, and then if it got to 10%, there was extensive wear, and you should think seriously about revising the bushing at least. And this is what I mentioned in terms of the Wright and Hastings study. Risk factors that they saw included post-traumatic arthritis and young age and high activity levels, not surprisingly. But time is also a risk factor. And so even with the rheumatoid patients, they will have bushing wear. Lee looked at a lot of the folks at Mayo, and their conclusion in terms of some of the bushing wear had more to do with young age as well, but preoperative deformity and the loss of condyles. And that goes back to what I mentioned earlier about Mike McKee bringing up not needing the condyles. And then finally, it has to do with osteolysis and aseptic loosening. And right now, there's a lot of argument about what that source is. There's one camp that advocates that the bushing wear and the polyethylene is causing the reactions and the loosening. The other side argument to it is when you look at a lot of the x-rays related to that, you don't see catastrophic osteolysis. The only osteolysis you see with it is really just around the joint implant. And so the other camp argues that essentially a lot of the osteolysis happening has more to do with micromotion related to cement techniques in terms of the implants. That's still to be determined moving forward. I will say overall, one final thing about all total elbow replacements is that right now in the US, I'm not sure exactly where the trials are, but Dr. Hotchkiss at HSS had gotten a grant through the NIH, and they're actually trying to develop a much better implant, and which is unheard of. There's never been actually, the NIH has never funded a total joint study in terms of that, developing the implant. But the point of the matter is there's a clear recognition that the implants that we have now are not ideal, and we need a much better approach to it. So, thank you.